The floor is yours. Thank you so much for being here. We're very excited to hear all about this new treatment. And again, everyone, he does have a hard stop because he's in the OR tonight. So we will be cutting things at 9 Eastern. And if we have to do a follow up in January, we can arrange that. So the floor is yours. And thank you so much for being here to educate all of us tonight.
All right. How many people do we have today?
We have
76.
76.
Wow, this is impressive. That's good. Well, again, thank you to all these organizers for the, I don't know if it's executive committee on Colon Town. It's a pleasure, and it's amazing what you guys do for all the patients that look and follow for advice and a support group, and for the families as well. It's very impressive all the things that you do, and special thank you for Betsy Post for giving this opportunity. So if some of you who has seen my previous presentations, a lot of times maybe I prolong too much. Maybe it's too much and it's difficult to keep the people focused on what I'm presenting. This area of histotripsy is new. So there is not tons of new things that I will have to share. Actually, there was a moment that I said, well, I think I need to share a little bit more. And I think I was lucky that I had the opportunity of getting 3 cases of histotripsy during this week. So I can share a little bit of that, which is like the first 3 cases in this country or internationally outside the trial. Let me tell you what is a trial important. A trial is when there's something that is not completely proof that they are offering for patients, which is not the standard of care, and patients accept to go. After something is finished, a trial, then the results are recovered and they are sent for FDA, and the FDA goes very deeply in the analysis to see if it's going to be approved. And this was a long process for this company, and I'm going to be talking about that. So I'm going to start sharing my screen. So why we should be worried and what is important about treatment of cancer and evolution is because many of us here already have been diagnosed with cancer, but many others were going to be diagnosed with cancer at some moment. Perhaps close to 50% of the people at some moment will develop some type of cancer. I'm not talking only about liver, but also other type of organ cancers. There's a lot of research that is happening behind, and a lot of institutions working very hard, but it's very difficult to be able to make huge progresses. In other areas, we have been able to make a lot of progress. An interesting area and a lot of progress has been done. It has been in colorectal cancer, breast cancer as well. But colorectal cancer, we have been able to make a lot of progress. But probably in the last few years, we have been a little bit stagnant. And what is interesting in this particular presentation of histosonics is I definitely think that if these start working and, you know, if there are resources for this company, that they will be evolving the way that they deliver this interesting energy that is ultrasound energy to other tumors. I think they will be able to control prostate cancer much better. I think so. They are doing trials. They're starting trials. Kidney cancer. They're thinking about pancreas. I want to leave it very clear. This is not the answer for destroying the cancer, killing the cancer, for being cured. No, no, no. It's a tool, a way to probably be cure some patients, very few maybe, but also a way of trying to get where we're gonna go when you're diagnosed with cancer. And I'm gonna concentrate in liver because so far it has been the only organ where it has been FDA approved. They are not opening it yet in Europe. It's only for the United States. And I got some pre-questions that I will try to answer during my talk. This everybody knows what is this. This is one of the most beautiful cities. That's the Étoile, the Arc de Triomphe. And you know that it's every visitor in Paris, they try to go and visit this beautiful place. Why did I talk about this? So if you see here, there are around 13 avenues that comes to this place. 13 avenues. You can reach this beautiful place through 13 ways. All right. And for me, that is what the patients should be trying to concentrate. Resection, or in very few particular cases, transplantation. And I'm talking about transplantation because this is something new that has been happening over the last 4.5 years in the United States in very small population. Okay, I'm not saying that transplantation is going to remove resection. No, surgery is the gold standard of liver cancer, of liver colorectal liver metastasis. That is the gold standard. So all the patient wants to get here, wants to get to that opportunity. The problem is, how do we get there? That's what it's the example here. The analogy that I'm bringing is there are different avenues. There are 13 ways or more ways of trying to come here. And this is what I'm talking about. You know, we have Y90, histotripsy now, systemic chemotherapy, hepatic arthroinfusion, immunotherapy, that is an area that is working on growing, resections, microwave ablation, Y90, as I mentioned. But this is not one way. Sometimes you're driving here, you want to reach here, and there's a traffic, or there's an accident, or there might be, a group of people blocking the street, uh, and then you have to take other little streets and go from resection to ablation, and maybe this is blocked because there's other problem there, and then you have to go to the Y90 Avenue. It's going to take you longer to get here, but the objective is to try to get into here, resection or transplant, because that is what is going to give the patients the best opportunity. So histotripsy, it's one of the new avenues to get here. I think we need to prove that histotripsy also could cure some patients. And I'm going to tell you why do I think it might be able, but for a particular patients, but more importantly, to be the path to be able to get in here. Now, there are some patients that we cannot attempt curative resections or curative transplant because they have disease outside the criteria, because they have metastases, unfortunately, in other organs, and they cannot be candidates for resection or transplantation. We need to prove that histotripsy might be able to bring a benefit for these patients. And I think what we have to do here is to start doing some trials. So a little bit of the history of histotripsy. Histotripsy started in 2001, University of Michigan, and they started doing a lot of investigations on this in the lab. And it took them 9 years while they were doing a lot of work to develop a company that is called Histosonics. I have no connection, or I don't get paid by Histosonics. I want you to know zero, okay? They are super nice people. They're working with us. We have them, a lot of them here during these last 3 days because we were doing the first cases, and we have a lot of support, but that is different. I have nothing to do with them. And this Histosonics, the company started developing. I recall, and I learned from these people that they started doing this with hearts. They were trying that with this ultrasound in babies, creating a hole between the atriums, between the two chambers of the upper part of the heart, to connect with some babies who have some problems in the heart. But I don't know. I don't think they went too far. And they start developing more things in the lab, and they start concentrating on focusing on liver therapy and prostate therapy. That's what they started doing. And then in 2019, they started with a study that it went to the FDA, where they show eight patients successfully treated. And this is feasibility. Feasibility means that it's a study that they treated some patients with tumors, they used the histotripsy, and the patients didn't have complications, didn't did worse. It's just to show it's not affecting this treatment. For getting into this area, they already went to a lot of animals models, a lot of animal models. And I will show you some animal models because it's pretty interesting. And then, the companies start getting involved. You can imagine there's a lot of resources that needs to create to grow a company like this. I think these guys, Johnson and Johnson, went and tried taking part of this. Then there's a fire. All of this is when they started the liver study, and they started in 14 sites. And this is the area of COVID. So they couldn't go to a very big institutions to try to do these studies because it was very difficult to be traveling. There were some people with special permissions to travel to Europe from the US for doing these studies. And then later on, they got financial approval from FDA after they proved that it was good, their trial. And I will explain what happened in that trial. And this is the 2023, the end. And this machine, one of these machines is here. I think they already have 8 centers who have bought the machine. They are delivering 2 in this year, one to here in the University of Rochester, another one in Cleveland. um, uh, Michigan is going to get their machine, despite they are the ones, the initiators of this in the research. They do not, the owners are Histosonic. And the machine that they have before, it was experimental. And now this is a new model. So they cannot use that one. They have to return it and they will get a new one. And then this is, the hospitals, it's very expensive and the hospital needs to deal with this. This is not in our hands as physicians. Now, what is this? So hopefully this work. So this machine deploys through this robot head ultrasound to the body. They don't need to open the abdomen. We don't need to open the abdomen. There's no needles. This is the liver, like if we're magnifying the tissue of the liver, these are the ultrasound waves that are coming across the abdomen and getting into the liver. And if we pretend that this is a tumor, there's bubbles that are created with the ultrasound that is going to be destroying that unwanted tissue. That unwanted tissue, particular, we're talking about um, what is tumors, cancer. So that is the objective of this. And they were able to prove it in animals that they were able to create tumors, and they treated these animals and they showed that it works. What does this create? It liquefied the cancer. It liquefied the solid tumor. And then that gets reabsorbed. They look at this with imaging for many months to those patients who they deploy the energy. And when it was well deployed, that substance of fluid was getting absorbed and the liver create a scar tissue and it disappeared the tumor. Now, this was exactly what it was happening in animals. And this is an example of this mouse. This is not my computer, sorry for that. But this is a portion of a spleen that they created cancer in a pig, and then they treated with histosonics to this tumor in the cat. They removed the piece of tumor, and they wanted to look how it looks. Sorry that I'm showing this. This cancer, there's a little bit of blood. I hope nobody. You can close your eyes if you don't like it. But well, you can see here. You can see they cut the piece. This is a spleen. You can see that hole. That's like a crater. The tumor was there, and now there's no tumor. It's all liquefied. It created that crater, and of course, with time, if they wouldn't remove it, they will create the spleen will create a scar tissue. They analyzed the pathologies, and they couldn't find in this specimen of animal any tumors. Now, what do I find very exciting? When they told me about this, I said, this is hard to believe. I don't think this is true. These are liver that was treated from animals with histosonics. And there was a tumor here in the liver. This tissue that you see here, these membranes that looks like a spider web here and here as well, those are bile ducts. Those are veins and arteries. So this energy destroy the tumor, but if there are veins and arteries or bile ducts around, it doesn't destroy those ones. And I was like, wow, this is hard to believe. I think they just want us to buy the machine. And how come is this happening? And I think it's the content of collagen of this structure that does not take the ultrasound waves, and only the tissue around it is going to be destroyed. And we need to calculate and focus our area of treatment so we can target. I don't know, it feels like military people when they go and shoot a missile and they do all their calculations. I feel like we're doing that when during these a couple of days that I've been working and doing this in some patients. So this is pretty interesting. They did other studies in animals, and you know, I know that this is very medical and very scientific, but it's very easy to understand. These three slides here in the bottom part are livers from animals in the microscope where they deploy um, chemotherapy to certain cancers, and there are the cancer. And the more shiny red is the penetration of the chemotherapy in the tumors. So these tumors didn't receive any histotripsy. These tumors only receive chemotherapy. Look at these ones in the top. They receive 5 pulses, that means 5 sessions of histotripsy, 50 or 100. So what is this telling us? That also, if perhaps, if this is in animals, perhaps if we treat patients with this histotripsy and we are treating them with some other immunotherapy or chemotherapy, most likely the penetration of the chemo or immunotherapy will get stronger in that tissue. So that is also pretty impressive. Again, remember, I'm not saying this is the answer for everything. We need to prove a lot of things, but this is exciting. Um, this is a very interesting effect that was described since 1950s with radiation therapy, and it's called the abscopal effect. What is an abscopal effect? Is when they were treating in animals and then in the trial in humans, some of the tumors, okay, they said, okay, this patient has 3 tumors in the left side in the liver and has, I don't know, 15 in the right side, a patient who has a lot of tumors. And they were considered that patient, they were considering perhaps palliative, and they were saying, there's nothing we can do for you. And the patient say, okay, I'll join this trial. Maybe I will get some benefit, or maybe I will help some people in the future. So they treated those 2 or 3 tumors in the left side, and they left the other ones non-treated because they couldn't reach with the energy those tumors. And interestingly, in some patients with the follow-up CT scans, sometimes the non-treated tumors got smaller. That is what is called abscopal effect. What I think is happening, and I want to do this in my research in my lab, is that what is happening is that liquefied tissue that I was telling you, it shows some RNA or DNA, and then your immune system is going to go and identify it, and then it will have memory and identify other sites of tumors, and it might go and attack. This is my theory, and some of the other people as well. We need to prove that. It's not saying, okay, let's treat one tumor and the other 20 are going to get smaller. No, but this is so interesting because what it's making me think is, wow, what about if we do this and maybe we give immunotherapy to the patient, because that will enhance the the treatment to the patient. So there's a lot of questions that we don't have. And I feel that this is the first time that I'm talking big time in immunotherapy on histosonics. I haven't talked about this in any medical field. So I think I want to be cautious with my message here. Um, what is interesting is there are a lot of local regional therapies. As I mentioned in that slide of Paris, France, you know, we have Y90, we have microwave ablation, we have the Paddock R3 infusion pump. There's a lot of other things but what is interesting of this one is that the effect is immediately. We have, apparently when we treat it, and then if I will go and remove the tumor, I will see the effect immediately. So we need to prove it because we need tissue in the humans to show that, and we're working on that here. This technology is addressing the concerns that could represent a major clinical advancement in this treatment. These are slides, these ones that I'm showing here, from the Histosonic group that I asked them if I can share it with you. So this is their trial, and I want to explain you this. I don't want to go too much into detail. There were several patients. The trial was called Hope for Liver United States and Hope for Liver International. These are the countries where that participated. And if we look at these, the criteria, you don't have to go into this detail. There were different type of tumors. Patients who have primary tumors in the liver, HCC, which is very common. It's more common in patients who have cirrhosis. They didn't treat any tumor more than 3 centimeters. Why? It's not because they don't think they can do it, because they wanted to be sure that they can demonstrate to the FDA this works. If you have a tumor that is 15 centimeters, most likely you won't have a very good outcome, right? But how do you demonstrate? Okay, let's go to the low-hanging fruit. We need to prove that it works. And then from there, you start expanding. One of the tumors that I treated on Monday, it was 4 centimeters. So we went bigger, and I think it worked. What they were looking at that trial, they look at the efficacy endpoint, and that was they follow the patients with CT scans, and then they wanted to see that the tumors were not growing back, the one that were treated. And they were also looking at that the patient didn't develop complications. Those were the main objectives. And as I mentioned to you, in the US, there were 25 patients. In Europe, there were 23, and in the UK as well. And then those 44 patients, in total, they have 49 tumors that were treated, and the patients were looked after several months, weeks. And the interesting part, let me show you, these are patients who have cancer of the primary cancer that has cirrhosis, and there were 18 of them, and 26, they have metastatic cancer, not HCC. So here there's a group of patients who have colon cancer or other metastases from other primary cancer. Could be from pancreas, could be from breast cancer, could be neuroendocrine tumors, but tumors that were going to the liver. This is an important slide that I want you to remember, or just to have my message here is, many of you have seen pictures or cartoons of a liver. This is a liver that is kind of divided in the segments. The liver have 8 segments. Here, the number 1 is behind. It's a very little one that is behind. Number 2 is like a clock. 2, 3, 4, 5, 6, 7, 8. So a clock that runs this way, but the number 1 is behind. So these are the number of tumors that they treated. What happened here in the right side, segment 7 and segment 8, they didn't treat any tumor. And here in the right side, in the bottom part, only 3 and 3. Why they treated 24 here? Why they treated 6 and 8? So if you see, the left side is from this vein to here, a lot of treatments in the left side and minimal treatments in the right side. One of the main obstacles of this technique are the ribs, the margin ribs, the costal ribs. They don't allow the ultrasound waves to go. So the liver, as you know, is covered by the ribs in the right side. And the left side is more kind of in the middle. So if you see the picture that here is the left side, the right side is here in the ribs. So it's very difficult unless they are very low in the right side, and you can treat it because they go below the costal margin. So that is one of the limitations. These people needs to create some way that we can penetrate or pass those ribs. And they should be doing that. And I think they have impressive engineers and software people. Hopefully they do that. I already told them, you have to do also, to be able to open the patient. I can move the ribs away with my retractors, and then with a hand piece, if you give me the Histosonic treated, the patient would have cancer. They don't care if you open or not open. What they want to have is a treatment that could help them for going to resections or getting cured. So I think the future is promising, and hopefully these people start developing more advanced. This is, I don't want to bore you with these, but the results of the two things that I told you about safety and efficacy, they got 95% of efficacy. What does that mean? That out of 44 tumors, 42 responded the way that they wanted. And you can see here, this is before the procedure, there was a little tumor here in the left side of the liver, was treated and created a cavity here. And that cavity, weeks later, months later, it disappeared and it heals completely. And in the other point, which is the complications, they minimal complications. 3 patients out of the 44 patients have some complications. The complications were one patient have infection, but this patient had a previous pancreas cancer surgery and have 20 metastases later on. The patient has some problems in the bile ducts. I think, I don't know this, and I'm not protecting them, but I think probably this complication is more related to the pancreatic surgery than the Histosonics. Another patient has pleuritic pain. I think probably that, what I can understand now is if you treat something in the left side that is very high, the ultrasounds can hit the pleura, which is in the lungs, and can create some inflammation probably. Um, Patients apparently don't need too much medication of pain after that. The patients were kept in the hospital for 1 day in the trial. Many of them, they wanted to leave the hospital. Um, our first patient left. The next day, we were talking and joking and talking about life and I think minimal pain. One of our patients that is really now in the hospital that we treated this morning before I started the surgery that I'm doing right now, I went to see him and he is doing very well. He told me that he feels like he doesn't need to be here. I want to be cautious. I think in the future probably maybe we can do this early in the morning and maybe the patient can be discharged in the late afternoon or early evening. But well, this is not the objective is not to do that. I think the objective is to understand much more because there are some limitations, and it's clear tumors in the right side, there are not our friends for these things. But of course, we need to find a way of using this. They concluded that this trial was good, FDA approved. It took them a lot of time for getting FDA approved. The FDA went back and forward, asking for some things, and everything worked very well. I did this. This is my slide that I put. What are the limitations? The right side, the rib cage. They only treated 3 centimeters tumors. Can we treat bigger? I think so. And one of the proofs is we did not 4 centimeters. I was planning to do another one that is a little bit bigger. We don't have pathology results in humans, but we will have them soon. There's a learning curve, right? It's taking us a lot of time it's taking some more time for preparing the patient. The patient has to be under anesthesia because the patient gets to the OR, no surgeries, no needles. The patient is intubated. So the patient is not moving while we do this procedure. We have to do an ultrasound, identify the tumors. One of the problems will be if we do an ultrasound and we cannot identify the tumors. That will be a big limitation, and that will be a problem because we cannot deploy this thing. So what I'm thinking is if I have patients here that could be candidates for these, I want to do an ultrasound before they come to the procedure to see if I can visualize them. Because otherwise we bring them here, we try to do it and we don't find it, and then the patient they go. Maybe it's just the anesthesia like a colonoscopy, very briefly, but well, it's better and it will be safer to avoid the anesthesia to have an ultrasound early. That's what we're learning. Now, what are the diagnoses and what are the indications? So, for example, if I have a patient with pancreatic cancer, right, that we know, and probably you all know, that pancreatic cancer is not very, it has a pretty bad outcome, unfortunately, majority of the time. And if the patient has metastasis in the liver, are we going to do histotripsy? If I would be doing a trial, for them, for those patients, I will try to do it. But I know that that patient won't have a benefit most likely. I prefer to try to keep that room for that patient that has metastasis from colon cancer or a primary liver cancer that I know that that patient most likely have a benefit, right? If my groups we start doing feel comfortable with this technology and we have more access, we will be opening for other diagnoses and opening for more and more and more for patients. But at this moment, we are limiting for the diagnosis of colorectal cancer, perhaps some neuroendocrine tumors, the primary liver cancer, cholangiocarcinoma, HCC. And you know that a lot of my work is based on colorectal liver metastasis. Let me share some of my um, experience. And I don't know if our super patient is here, but this is our patient number one. And I asked permission if I can share some of her images. And this is here. You can see there are tumors in the right side of the liver, right? In the left side as well, you can see this one here and a lot of here. Initially, when I met this patient, I said, I think I might be able to do an ALPS. Why is that? Because I need to remove a lot of or a lot of tissue in the liver in the right side. The left side also has cancer. So the only part that there was no cancer was in the center, in the segment 4 of the liver. And let me remind you what is an ALPS. For example, in this cartoon that I have here, I put some metastases in all of this area. And then the first stage, we go and remove the tumors, for example, in the left side. Then now the left side is clear, but it's very small. If I remove now all the right side, this patient won't survive because it's too small. So the idea was to remove that, ligate these veins here, all the blood flow from the portal vein will go to the left side. The liver will grow in 7 days. This little part with no cancer will grow very big. And now I can come back in a second surgery and remove the right side, and the patient won't have liver failure and will end like this. So I have the opportunity of being a pioneer on this technique, and I think it worked. But I think we have to be more cautious because um, these are the results. Patients, majority of them, they will have recurrence, most likely, but there will be a big opportunity for doing other things. So what I thought about, okay, look at these patients. This patient has colon cancer, and the primary tumor is in the sigmoid. Patient received 10 cycle treatments of FOLFOX. There's a mutation of KRAS. The CA was extremely high, but then by November, it came down responding very well to chemotherapy. Should I do an ALPS? And that's what I initially thought. Look at this amount of tumors here in the right side, a lot of tumors, and this big tumor in the left side, and another small, very superficial here in the left side. So the only area where there's no cancer is here in the center, that's segment 4. So I thought, okay, I should be doing an ALPS. And then when I start getting more involved with this histotripsy, I said, wait a moment. I start thinking, and this, I don't know, it came one day while I was taking a shower and say, what about if I do this? What about if I use histotripsy here? Right? Because this is the tricky one. And my plan was to do histotripsy in those tumors in the left side. Now, hopefully that left side of the liver is clear. Give more chemotherapy, wait to see that there's no cancer back in the left side, and then I can safely come and do surgery in the right side and do a right hepatectomy. Can I do that? So we're halfway there. And this is where we're going. So we did this. We developed this um, technique of histosonic in our patients. It creates that micro bubbles that we can see with the ultrasound, and it creates a very interesting sound. It's a little bit hurts the ears, but that is good when you're doing this procedure. So my goal is, okay, let's target this tumor here. And remember what I told you about that it preserved the vessels? You see these white structures here? Those are veins that she needs to survive if I do a right hepatectomy later on. So with other type of ablation, I wouldn't be able to preserve those. And this is another patient. This is a picture from today. This is not our first patient. This is our third patient. And here is Dr. Tomiyama, which is my colleague, my super colleague. Here he's here. I'm here as well. I know that it's a little bit blurry picture. It was not the best cell phone. All of these are the people from Histosonics that they came from Minneapolis, from California, to support us in the OR, engineers that they deploy the machine. This is the machine here. This is a robot arm. This is a bubble of water that is hanging from the robot arm that has the ultrasound. The patient is anesthetized, and this is the ultrasound machine. So this ultrasound is helping us to see the tumor. It sent the images to this other machine, and here we managed to deploy the energy. And this is how we do it. We have in our hospital, we have other monitors where we can see CT scan for fusion of the images and be able to see things much better. So this is the case of our first patient. This is tumor here. You might say, okay, this is the same. No, it's not true. This is not the same. There's no tumor anymore. This is a cavity. And you see the shape is different. And why does it goes like a elliptical, like an egg? I think it's because the patient is moving up and down during the breathing. So the treatment moves a little bit. Now here, this is the area, the bottom part where the tumor was located, and then the treatment extension went a little bit beyond into this area. But what is important thing now, our patient, all these left side of the liver and the segment 4, hopefully there's no tumor. That one that was in the surface that was very small, my plan is to go in the operating room, hopefully in February, after some chemotherapy, remove it, take it out, and do the right hepatectomy. And the primary tumor will remove it in the first stage, in that stage. Now the patient doesn't need 2 operations. Now the patient needs only 1 operation, hopefully, if this works. We need to prove that it works. But I think this is exciting. We have to be cautious, as I mentioned, and I think one of the things that I learned from a surgeon who I love all surgeons who they teach me and I learn from them from what they were pioneers many years ago. And one was Dr. Blumgart. And here he is, where I was in New York City with him. He passed away 1 year ago. He was from Memorial Sloan Kettering Center. He is one of the persons who came from South Africa and started what is called HPV surgery in the United States, a hepatopancreatic biliary surgery. And one day I was asking him when I was doing these ALPS, and then I was starting liver transplant for colorectal metastases. I asked him, Dr. Blumgart, what advice do you have for me in my life? And he told me festina lente. And I didn't understand very well what does that mean. And this is what he means. Uh, we have to make haste slowly. And he was telling me you have to be like a rabbit, but like a snail at the same moment. And I kind of understand his message. And I was asked to write a paper in the American Journal of Transplantation, a critic of a paper, and I call it that festina lente, because I think that paper particular, they were kind of rushing on trying to do things. And so I just want to share that with you. Not that paper that I talk about liver transplant for colorectal metastases, but I try to I love innovation. I think we have to be cautious. It's not going reckless doing things. I think we have to go slowly. And at the end, I want you to remember this, what I mentioned at the beginning. The important thing is trying to get there. It doesn't matter if you one side, the other side, or you have to go one, and two, and hopefully you are able to get here, right? This is the important thing. And how do you do that? You need to have a lot of courage. And I think you need to have a team and a group of physicians, a surgeon or surgeons who reach the goals for you and to help you driving that part. And with that, I finish my presentation and I will stop sharing.
Thank you so much. I know we don't have a lot of time with you, but there are some questions. So I thought we could take some of these questions. It's 8:46, and I'm going to get you out of here by 9. So we're just going to take the questions that we can.
All
And
right. And I will try to answer hopefully short
yes,
and clear.
yes. And then if we want to do a follow up, we can work on that later. So if a patient does have a few small lung mets, would that rule out this procedure if there's only one liver lesion?
All right. So I don't know. If the patient comes and it's in the left side, right? As I mentioned to you, if it's in the right side, I would say this patient, we won't be able to treat it. But if it's in the left side and those, yeah, I think it will depend. I think it will depend if the patient is telling me, okay, I have 20 tumors in the lungs and one in the liver. I think there's not going to be a benefit for that. I don't think there's going to be a benefit. Okay. If the patient has two small lesions in the lungs and they have been stable and they have been there for 6 months, 1 year, wait a moment, and there has one lesion in the left side. I said, wait a moment, I can go do it. But also I will tell the patient, maybe I can get one of my thoracic surgeons here and get the two lung metastases out. So, um, as I mentioned in my last slide, is we need to think sometimes a little bit outside the box. We have to go festina lente, not go crazy, right? But I think it will depend on the characteristics of this patient. So if the patient is not responding and is progressing, probably we know that the outcome would not be good. But I wouldn't be closing the door, but I will have to analyze very carefully the diagnosis, if the patient is responding or not to chemotherapy.
Okay. The next question is just about, do you know what other facilities outside of URMC have the machine right now? And you
Yeah,
may or may not know that. So,
I asked them because I know I was gonna get at that question, Betsy. So Cleveland Clinic got the machine. I think they are planning to do next week their first case. That's what my understanding. Um, Nobody else will start cases in this 2023. But I think in January, um, Wisconsin is starting. They have put out 8 machines in total by early next year. To my understanding, also Michigan is getting their machine. NYU is getting a machine. Um, I think Hopkins is trying to get it, but they haven't conclude and close a deal. But there has been 8. I think I think by the end of 2024, probably there will be around 10 to 12 machines out there. And the important thing is to be able, it's very interesting because as a surgeon, we normally as a surgeons, we try to go with a mentality of saying, okay, let's go, let's resect, let's do a transplant, let's do a resection, let's help the patient. Um, and trying to be smart on the way we do it. But with this is a very different mentality of about, calculating. I don't get scrub, right? It's very strange for me. I don't get scrub. I'm not wearing OR gloves and all my gown. It's different. But I think as a surgeon, what it makes me feel very comfortable is because I know where the patient needs to go, and I know what surgeries the patient probably will. And this is I see many times as a bridge, as a path to get into that resection, to get into that transplant. I think this is giving opportunity for patients.
great. The next one I think is a quick answer. Does getting this still leave the option of surgery and perhaps an HAI pump later?
I don't see why not. I would say the answer yes. I think that, as I was mentioning, remember those little streets that I wrote in the
Yeah.
map, right? If you have one, you can go to the other one. There's some things that you cannot. So if you have an Alps, for example, a resection of an Alps, and then you're saying, I'm going to get a pump, I haven't seen anybody in the world doing that, right? And I think it will be very dangerous. So I think if sometimes when you go to one path, you won't have the other one. And I like to be very honest and clear with my patients, right? My first patient was saying, can I still have a pump if the isosonics fail right now? Yes. If I go and I do an ALPS, you won't have an opportunity of getting this, right? A hepatic artery pump. That's clearly. But we have to be very clear. Patients know they come with a lot of education nowadays, seeing especially those ones who have advanced metastatic disease in their liver, and we need to provide opportunity and education.
And
Can
then
I
can
answer
this
that question? Can I answer that question that is right now there that I saw about the insurance? Insurance is difficult. I want to be polite. Insurance are difficult. It's true, Betsy. They're very difficult, but we were fighting with them, and I talked to them peer to peer, and I explained them what is we're doing. Um, and we didn't have problems. I think, for example, patients who go for transplant, for colorectal metastasis transplant, that's very difficult because it's huge, and they don't see some of them they go for experimental, but these they see like an ablation, so it's less difficult for patients, and the cost to the insurance is not huge compared to, you know, a big transplant or big resection. Of course, um, I wouldn't say this is better than transplant or this is better than resection. No, each is different streets, different avenues. Remember, we're gonna get to the center and get into there, but that's it.
so this one is, can this be used on just one tumor if others exist? For example, if there's a tumor at the top where all the veins and arteries meet. So can this be used on one if there are
Yes,
other tumors?
yeah.
Okay.
If the tumor is located more towards the left, so it's not necessary to be the left. If the ultrasound has access to the liver, and if the liver is not is if the ribs are not blocking, the ribs are like I was a little bit frustrated this morning with our second case. The ribs were obstructing us, and we couldn't. And I have to be honest, we couldn't treat two of the tumors that I was planning to treat in that patient. And it's because of the ribs. The ribs were blocking, so I need to come and bring the patient a plan B. And I already talked to the patient. We woke up the patient, and I told the patient, I'm doing on January 5 left hepatectomy. Um, it's going to be a more aggressive treatment, but I think we're trying to find answer for patients, but there's limitations. I want to be clear. This is not the answer for everything, right?
Right. So if a patient has surgery to remove the primary colon tumor and additional mets to lymph nodes, could they be a candidate for this to do the rest of the job and stay on systemic chemo?
Okay. So if a patient has the primary tumor removed and lymph nodes, but if those lymph nodes, remember, if those lymph nodes are around the primary tumor, and there are metastases, the problem is when there are lymph nodes not only around the primary tumor, when they are lymph nodes in the retroperitoneum, which is in the back part, and if they are lymph nodes around the liver, and if those are malignant lymph nodes, the prognosis is worse, and sometimes it's not. We have to be very cautious. So I wouldn't do surgery or something big in those patients. I will be waiting because the time is going to tell me if I should be aggressive or not later on. So what I do is Tosonics in because the patient have lymph nodes, but then the patient received treatment and then I cannot see those lymph nodes. Well, I will go and do Tosonics or even do surgery, right? Perhaps not transplant because we give immunosuppression and those lymph nodes might come back with immunosuppression and the cancer can come back and spread to other places. But I think it depends on each patient. I wouldn't say no, but if there are multiple lymph nodes around the liver, and then probably the benefit will be remote.
Okay. We have 5 minutes and I'm going to hurry. So,
They haven't called me. I have my
okay.
cell phone here, so they haven't called me.
Does the number of existing tumors factor into eligibility for this procedure?
Does the number of liver tumors? I think with time we'll be learning more, and I think we're gonna get smarter on how we do these things. I will feel comfortable with just what I have learned in the training and what we have been thinking that we can treat maybe two or three tumors in one session. It takes more time. It takes like I don't know, like close to 2 hours or hour and a half to prep, to make the measurements, to make the fusion, to develop your plan. of attack. And then when you have all your lines draw, and then you just press a button, and then you just wait. And then you have to be standing beside the machine, listening how that is working well. And that treatment could be, I don't know, 10, 12 minutes, or it could go to 40 minutes. But I will be able to treat 2 or 3 tumors in one session. Now, of course, if a liver is full of tumors, that means that there's some in the right side, so I wouldn't be doing it. But I think if I'm able to treat the left side with histosonics and clear those cancers, then I can go and do surgery in the right side, correct? And probably the patient can be no evidence of disease. We know that there's a chance of recurrence, but we will follow that patient close. And that will be the best prognosis for those patients.
How will you get pathology results if the tumors are liquefied in the process?
Great question. Great question. So my patient from today, I treat 2 little tumors that were in the bottom of the right side, close to the gallbladder. So they were like not hanging, but just beside it, below the costal margin, below. I treat them. And there's another very big that I have to go and do resection in the right side above. So I cannot do histotripsy. So that patient is going to go to the operating room. You know that because I have to go and remove it. And I will have those other 2 little tumors over there that I have been treated. It will take me 5 minutes to scoop them out. I'm going to do that. And I will be able to answer a question for that question soon. And nobody has that answer yet. So hopefully we can bring good news soon.
Awesome. Someone's asking, what about a tumor 11 centimeters? Could you explain, like, would that be something that would be possible or not?
I don't think anybody has tried that. Um, I will be afraid of doing it. If it's a tumor of 11 centimeters, I'm not sure if it's in the left side. Probably will be more into the center of the left side because the amount of tissue of the liver. But even if it was in the left side, I I would think about other options. So I will offer surgery. I will offer a Y90 and then surgery, depending on what type of tumor it is.
Okay. So someone's asking the location of the tumor on the left side and away from the biliary tree and blood vessels is needed for this to be used.
I
So the
think
utility would be a subset of liver mets.
I would say the the applicability, the utility of these would be hopefully they are in the right side, sorry, again, repeat it, not right side, okay? Left side. Hopefully they are in the left side. But what is impressive is even if they are beside the bile ducts or beside the arteries or veins, we can preserve with this technology, with this ultrasound, and we can preserve that tissue. So it's not a problem. With other ablative therapies, we cannot use it because we will create bleeding or bile leaks.
Okay. I'm just going to there are a lot of questions and I don't know that we're going to
No,
get to them all.
no,
So
just carry on. Don't worry.
is the procedure available if you currently have a hepatic pump?
Good question. I don't know. I think so. Why not? I think it wouldn't affect. It wouldn't affect. Um, I don't think it will affect. Now, sometimes some patients with the pump, um, sometimes some of them can have biliary complications. So if there are bile ducts that are very dilated, probably I will be very cautious with that. But if the patient doesn't have those complications and no bile duct dilations, and if it's in the left side and we can see it in the ultrasound, I think I might do it. I would do it.
Is this an option if liver function levels such as ALT, AST, alk phos are high and bilirubin is stable?
Wow, well, great question. So Koji Tomiyama, uh, we both work together, and we think we always think that two brains for eyes, for hands, we can do more for patients, and we have other surgeons. I don't want to minimize the work that two of the other surgeons are right now taking my patient to operating, and I will join them soon. So I what I think is what he says, Dr. Tomiyama, is that the interesting part of this technique is that it doesn't affect the parenchyma. The parenchyma is the tissue of the liver, because the waves where they are traveling through the liver to get into the tumor, the waves do not injure the liver. They only injure the tissue when they collide the forces for three or four areas that are coming. But when they are traveling and go through different tissues, they don't affect it. So for the question of patients who have, for example, cirrhosis, and they have or hepatitis, and they have inflammation of the liver, then this could be an option of treatment for them.
Okay. Um, this one is about if the patient has already had a liver resection and also ablation, but they are getting a few 1 centimeter, small liver mets back in the liver. Is this something on the left side, those mets kind of continue to recur? Would this be something that could be an option?
Yeah, if we can see them with the ultrasound, I think so. Yeah, why not?
Awesome. In other centers outside of URMC, would this typically be within the surgical department or surgery or IR or another specialty?
That's a very smart question. I think that question that someone is in the medical field. Um, this is a very smart question because um, I think I'm biased in this answer, right? I'm a surgeon, but I think IR thinks one way, surgeons with see other way. But normally ablation therapies, microwave ablation, or when we do Y90, there are my friends, my colleagues who are in IR, and I need them a lot here. But the way of thinking is kind of they're not seeing the patient and the follow-up continuously and treating the cancer, right? So it's just a passage through them for a period of time, or a short period of time. And I think when the surgeon has this device, the way of thinking is different, trying to create that bridge, right? Because otherwise, the patient normally is referred from the oncologist or the surgeon to the interventional radiologist for having, SBRT or having a microwave ablation. Um, so definitely, I think I asked to the Sosonic people if there are more surgeons or more interventional radiologists, and they said that at the beginning the interest was more from interventional radiologists, but now who has been buying it are departments of surgery, and they said that it's around 70 to 30%, 70 surgeons, 30% interventional radiologists.
Awesome. Is a MET in segment 1 an option for this procedure?
It's pretty deep. Segment 1 is very back. Probably if it's a little bit large and we can see it well, um, what I will do with a patient like that, if a patient has a segment 1 tumor, um, I will try to see the ultrasound, if we could see it in ultrasound. But otherwise, I will go and resect it, right? So again, we need to think this is not the only option. There are other options, and I will go and say, okay, I can go and resect it. And if they tell me, well, we cannot resect because it's beside the IVC, well, right now I finished this and I have to go and replace an IVC in a liver transplant. So I'm a liver transplant surgeon. That's my business.
Would someone that had had a failed PVE be a candidate given that they have less liver volume?
Yes, so this helps for those patients who have less liver volume because it preserves more liver volume. We don't have to go and resect too much.
Okay.
If the tumors are more in the left side, right? I know I'm repeating this too much, and hopefully, I don't know, in 2 or 3 or 4 years, this uh, group comes with an idea of saying, okay, you know what? Now we're dealing with the right side. That would be phenomenal.
Um, is this something, can innumerable mets to the liver be addressed if they're small but tiny?
I will have to see the images. I wouldn't be able to answer that. I will need to see the images. If they are little, probably not. You need to have at least some size. 1.5 to 3 centimeters.
Okay.
If these are the ones that are little ones, it will be very difficult.
Is there information on the complication rate of this versus ablation?
So, in good places when they do ablation, the complication rate is low. In good centers, people who are talented. Um, of course, if the tumor is located in the segment one, right? If it's more complex, or if it's very high, then very close to the lungs, it's more complex and they have more complication rate. But normally, the complications would be, for example, bleeding or an injury of a small bile duct, which is not common with normal ablation, with microwave ablation or radio frequency ablation. But with this, of course, the isosonics, there's not too much data on those patients who were treated. Only three have some complications, as I mentioned, and one was infection because of the pancreatic surgery, another one was pain in the chest, and the third one I don't remember, but it was something that with Tylenol only disappeared. So minimal. Hopefully, we will have more patients who will be able to share their outcomes.
Okay. There's two more. How does this differ from SBRT?
I think it's very different. So, SBRT, it's a very different technique, where they're gonna go and deploy some microspheres, and it will have some radiation, and then this will be different. You'll have to wait for 3 to 6 months to have the peak of the treatment, and you will have it works very well in patients who have certain type of tumors, specifically, for example, cholangiocarcinoma, HCC, because this is where we started using this technology. And nowadays we have started using it in colorectal liver metastases. It's not our first line, it's not our preference immediately, but it's an option that we can use. It's not the main street that you use for trying to get to resection. It's not the main street to try to get used for transplantation, but I use it few times when there is some complexity, and you cannot get there very easily. Then I change streets and use it in our patients.
Someone said the use in conjunction with immunotherapy is intriguing. Can you explain how this makes sense with immunotherapy?
Um, because what it's believed that is happening is when you liquefy the tissue, your immune system, the patient's immune system, because there must be some RNA exposed or something like that, your immune system identify that. And then the immune system, your lymphocytes and your antibodies are going to go and attack that. And probably they identify, oh, there are other tumors. They are enemy tumors, and they will go and attack them. And maybe they will start reducing in size. Now, if you give immunotherapy, then you're enhancing the immune response. So that immune response, the abscopal effect that you started with histotripsy, might get enhanced with immunotherapy. This is just thoughts, okay? Don't take these. This is not, we haven't been able to prove this. We need to prove. There's a lot of research that we have to do in the lab, right? But this, I'm just trying to see, to tell patients there's things that are going to come in the future. There's hope. We have to do a lot of work in the lab, and help those patients.
Um, let's see. Is a patient with positive ctDNA eligible?
Yes.
Yes. Okay. What if I don't have a left-sided tumor? I only have one big right-sided tumor because I had a liver resection. Now I have a recurrence.
Is it colorectal metastasis? I would say yes, probably. Um, well, if there's no, what I would think, I don't know, just thinking very clear. So if this patient, for example, has a left hepatectomy and now has recurrence in the right side, but the patient is responding to chemotherapy and the primary has been removed, and there's no evidence of disease outside the liver. You know, Betsy, what I'm gonna say, right?
Yeah.
Why not transplant? Okay, why not transplant? Right? Patient might be cured with transplant, might be. So changing streets.
So, from what you've described, it seems multiple beams have to converge in a spot for this to happen and work. Is that why the tumors have to be a certain size?
Yes, and I think they did it from 3 centimeter tumors because they want to show that it was good, visible, and as I mentioned, the low hanging fruit. And now it's time for start pushing the envelope cautiously and then do those tumors that are a little bit bigger.
I think we only have one last question. If a patient is accepted for this treatment and lives out of state, what is the frequency of follow up required at your location?
I will do with follow up by imaging. And we do a lot of teleconference. I do a lot of telemedicine with our patients. We have a lot of patients from outside the state, and we communicate with their oncology team or their cancer team and give our recommendations, right? And we see them every 3 months or as often as is needed.
Okay. I'm going to ask one last question just so that I'm super clear. What is the maximum size? Like with ablation, I know we hear, generally speaking, 5 centimeters or less. Is that something that's similar with this, or did you say? I can't remember.
No, and well, it was 3 centimeters in the trials, and Monday we did one that it was around 4 centimeters or a little bit more than 4 centimeters. The one that I show you in the pictures.
Right.
Um, if I have a 5 centimeters, I will do it. Probably I will do it in 2 sessions because the bubble that creates that bubble of those bubbles, the cloud, it's called the cloud of bubbles. I think it generates around 3.5 centimeters. So I will do one session of maybe half of the tumor and then the other half of the tumor with another session. That's what I will do. We have to come with innovation and be creative here because there's not too much data. So we need to generate that. But I think it will be safer if it's in the left side, we can reach it, and if it's 5 centimeters, I think it will be. If you tell me it's a 20 centimeters, if a 12 centimeters, probably wouldn't be the preference. I think we're not there yet.
All right. Well, I just wanted to thank you so much for all of your time. Let's see. Yeah, I think Julie answered the last one. Thank you so much for all of your time. I know we went a few minutes over. I feel so terrible about that, but you're always so generous with all of us. Thank you for educating us on this. And I know that we'll follow up with you again soon and you'll have updates and you'll continue to keep us all informed. We wish you a happy night, a successful night in the OR.
I hope it looks difficult, but well, I appreciate your time. Thank you again to everybody from the group of Colon Town. Thank you, Betsy, for this opportunity to all the patients and their families. It's amazing what you guys do for your beloveds, and I wish you happy holidays to each one of you and and a happy life.